Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A warm welcome to all the esteemed faculty who have gathered here today for today's event, which is on key issues in obstetrics and gynecology. We have two very eminent speakers, and we have three fantastic chairpersons who will be here during this event. And of course, we have the entire audience who has joined in across the length and breadth of Maharashtra and the rest of India. So, warm welcome to everybody. I'd like to start by expressing my gratitude. Next slide, please. To our esteemed President, Dr. Nandita Palshetkar, current President of AMOX, immediate past President of FOXY, a past President of IAG and the Mumbai Society as well. She's always been there as a guiding light and supporting us in all our academic endeavors. Next slide, please. I'd also like to express my gratitude to Dr. Arun Nayak, who is the Secretary of AMOX. Similarly, he has also been a guiding light to us and encouraging and promoting his juniors throughout the years. Next slide, please. I would also like to express my gratitude at this stage to two very important individuals. Number one is the chairperson of ICOG, Dr. Mandakini Megh, and second is the secretary of ICOG, Dr. Parag Biniwale, for granting us the ICOG credit point last minute for this event. I know they are swamped with work, and apologies for putting them under pressure and applying last minute. We'll try and avoid that in future. We have three very stalwart chairpersons who are here today. The first is Dr. Rajendra Singh Pardeshi. Sir is the immediate past Vice President of FOXY and the current Vice President of AMOX. He has an unparalleled distinction of having won 6 times Best Paper Awards at AICOG conferences, faculty at several national as well as international events, and he is known to be somebody who is very distinguished as an academician and also in AMOGS and Aurangabad. Thank you so much for joining us, sir. Next slide, please. We are also delighted to welcome amongst us Dr. Sujata Dalvi. She is an honorary clinical associate at the Wadia Maternity Hospital and Jagjeevan Ram Hospital in Mumbai, attached to several other hospitals in Mumbai. The assistant editor of Jogi, member of the managing council of Mumbai Society since 15 years, and the joint secretary of AMOGS. Madam is a little busy with a patient. She'll be joining us very soon. Thank you so much, ma'am, for being here. Next slide, please. We have with us Dr. Mala Raj. She is somebody who is well known in the field of endoscopy and OBGYN as well. She is the secretary of the IAG Tamil Nadu chapter, a managing committee member of the National IAG, executive committee member of OXY, and she has been a past secretary of IMS Chennai chapter, also well known as a FOXY endoscopy trainer. And we're delighted to welcome her on the AMOX platform. Thank you so much, ma'am, for joining us. We have two very distinguished academicians who have joined us as speakers for today's event. We have Dr. Biswajyoti Guha. Sir is somebody who is an eminent academician from Kolkata. And according to the program, he was supposed to speak first, but he is requested to be allowed to speak second. And we have with us Dr. Kalyan Barmade. I know him since almost 30 years, since our undergraduate years in KM Hospital in Mumbai. And for his formal introduction, he's now, of course, become a very senior stalwart OBGYN in India. I can no longer think of him as a KM undergraduate student with me as a contemporary. He is now the treasurer of IAG and a zonal coordinator of AMOX. But for his formal introduction, I will hand over to the chairpersons and I request Dr. Rajendra Singh Pardeshi, sir, to please introduce Dr. Kalyan Barmade.
Good afternoon, everybody. First, I wish to express my sincere thanks to AMOG, Dr. Nandita Palshetkar, Dr. Nayak, and our active chairperson, active energetic chairperson, Dr. Pratik Tambe. He is doing excellent work in endocrinology committee. To introduce Dr. Kalyan Baramde. I think Kalyan, other than Kalyan, I think Dr. P.A.C. Baramade. I don't think he needs any introduction. PAC means Public Awareness Committee. So all is known as Public Awareness Committee has taken the committee on the height in the Fox's so many programs, more than 304 programs he has done. That is, I think, this is the biodata of Dr. Kalyan. Now recently he has elected as a treasurer of IAG, is chairperson of Public Awareness Committee, treasurer IAG, president Latur Obstetric Gynec Society, organizing secretary LOGS IAG Conference 2014, organizing secretary first UIAG Conference Latur, organizing secretary Endoworld Conference 2018, convener first Pride IAG Conference December 2020. And there are many awards and achievements also. So to start with, I would like to invite Dr. Kalyan Baramde. He will guide us on current concepts in the management of endometrial hyperplasia. Over to Dr. Kalyan.
Thank you so much, sir, for such a nice introduction. And you are the one who has brought me into Foxy. So I bow from my, I bowed in front of you, and I'm really thankful to you from bottom of heart. I'm really thankful to AMOG's President, Dr. Nandita Palchatkar, Madam, Secretary, Dr. Arun Nayak, sir, and Vice President, Dr. Rajendra Singh Pardesi, sir, to give me this opportunity to talk on this topic. And also, I'm thankful to Dr. Pratik Tambe, sir, who is over enthusiastic and my senior from KM, proud to be his undergraduate student and his resident. Thank you, sir, for this opportunity. Now we are going to start with endometrial hyperplasia. What are the current concepts? And I'm going to start this as a 30 minutes lecture and 10 minutes for question and answer. Human reproduction is a complex process. It starts with follicle formation and ovulation, followed by implantation and corpus luteum formation. As everybody knows, uterus is a complex tissue. It contains many cell types, which undergoes dramatic phases of proliferation and differentiation. It is a steroid hormone responsive organ, which is a paracrine organ. Before going to the endometrial hyperplasia, I think we should know the effects of estrogen and progesterone in the ovulation cycle itself. As everybody knows, in the first half, that is proliferative phase, estrogen dominance is there. And the second half, that is secretory phase, progesterone dominance is there with the estrogen. So, anytime there is an endometrial response to abnormal level of steroid hormones causes anovulation. As everybody knows, estrogen acts on the glands, progesterone acts on the stroma. So anytime there is a hyperestrogenism, there is a poor stroma, and there is a degradation of the microvascular system, which causes anovulation, and it is the main precursor of endometrial hyperplasia. Endometrial hyperplasia is characterized by proliferation of endometrial glands of irregular size and shape. When compared with the proliferative endometrium, there is an increase in the endometrial gland to stroma ratio. If glands increase, that means there is a hyperestrogenism. So, endometrial hyperplasia virtually always results from chronic estrogen stimulation unopposed by the counterbalancing effects of progestrogens. It has a spectrum from benign to become malignant. Hence, it is important to understand its presentation, risk factors, diagnosis, and management strategies. As everybody knows, in 1/3 of the cases of CA endometrium, there is an endometrial hyperplasia. That means 3 to 4 patients who have endometrial hyperplasia can convert into an endometrial cancer. Nowadays, there is a newer system for diagnosis of AUB, and which is palm coin classification coined by FIGO. Here, it is AUBM as malignancy and hyperplasia. So it's a structural causes which are discrete in nature, can be measured visually with imaging technologies and histopathology. Presentation of endometrial hyperplasia, that is abnormal uterine bleeding, which can be heavy menstrual bleeding, intermenstrual bleeding, irregular bleeding, or unscheduled bleeding on HRT treatment. And even sometimes it can mimic as a postmenopausal bleeding. So once you know the risk factors, you are there to diagnose the endometrial hyperplasia. Whenever there is an increase in the BMI, that is body mass index, with excessive peripheral conversion of androgens in adipose tissue to estrogen, prolonged annulation associated with the perimenopause or PCOS, estrogen secreting ovarian tumors, drug-induced endometrial stimulation, that is the use of estrogen replacement therapy or those on long-term tamoxifen, and sometimes family history, genetic factor is important. So in risk factor, simplified is obesity, those patients with early menarche, and those patients with late menopause. These are the patients where you are supposed to diagnose endometrial hyperplasia. Investigations which can point out the cause. So the checklist of investigations is history of what type of bleeding it is, clinical examination, then blood reports like CBC, sugar, creatinine, and LFT. And the most important is transvaginal sonography, preferably by a color Doppler. Endometrial sample histopathology is diagnostic, and in rarer cases, you can require hysteroscopy also. And hysteroscopy and histology is important for the diagnosis. Diagnosis of endometrial hyperplasia requires histological examination of endometrial tissues. Endometrial surveillance should include endometrial sampling by outpatient endometrial biopsy. Mind you, there is no role of doing a DNC for diagnosis of endometrial hyperplasia. In an OPD basis, you can do an endometrial biopsy with PIPL, and that is how you are going to get the sample. If it is not available, the smallest cannula of MVA also can be used for endometrial biopsy. It's always an OPD basis procedure. Diagnostic hysteroscopy is a rarer required in some cases, which is considered to facilitate or obtain an endometrial sample where outpatient sampling fails or is a non-diagnostic. What do you mean non-diagnostic? That means there is a polyp where you are not going to get a sample out of it. That is where hysteroscopy's role comes. Direct visualization and biopsy of the uterine cavity using hysteroscopy should be undertaken where endometrial hyperplasia has been diagnosed within a polyp or other discrete focal lesions. The most important tool is transvaginal sonography, which may have a role in diagnosing endometrial hyperplasia in both pre and postmenopausal women. But TVS detects an irregularity of the endometrial profile or an abnormal double layer endometrial thickness measurement would give further reason to perform an endometrial biopsy in a woman with postmenopausal bleeding. The role of ultrasound in premenopausal women is restricted to identifying structural abnormalities, as there seems to be an overlap between normal endometrial thickness and that caused by endometrial disease. How do you diagnose? Broadly, in a premenopausal age group, wherever it is more, endometrial thickness is more than 10 mm, and cutoff in a postmenopausal women is more than 5 mm. So transvaginal sonography, which is a gold standard diagnostic tool, where you can diagnose the polyp, submucous leiomyoma, polyp with a feeding vessel, secretory endometrium, endometrium in a proliferative phase, and endometrium in a late proliferative phase, like a triple line endometrium can be seen. These are different types of endometrium which can be diagnosed, and you can diagnose very well endometrial polyps on TVS, and even on 2D ultrasound, you can diagnose endometrial polyps. If you put an color, and if there is a feeding vessel, you can diagnose it with the TVS color Doppler as well. When you're going to do a hysteroscopy, as we have discussed, it is an additional endometrial assessment which is necessary if abnormal bleeding persists, or if an intrauterine structural abnormalities such as polyps are suspected on TVS or endometrial biopsy. Hysteroscopy can detect focal lesions such as polyp that may be missed by blind sampling like PIPL. It is used to facilitate or complement the endometrial biopsy where sampling is not possible or non-diagnosed. And directed biopsies can be taken instead of a blind PIPL. Hysteroscopy, these are a few pictures where you can see the normal endometrium with glands in the secretory phase. And this is a small polyp. These are the different cases of endometrial hyperplasia with the vasculature which are seen on hysteroscopy. You can see cystic hyperplasia. In 9% of the cases where you are suspecting endometrial hyperplasia, it can be a polyp which is seen on hysteroscopy nicely and which can be removed in the same setting of office hysteroscopy. We have to have caution of malignancy whenever you are doing a hysteroscopy. Only thing which you have to remember whenever you are suspecting malignancy during a hysteroscopy is you have to keep your pressures of saline hysteroscopy to minimum, that is 60 to 70 millimeters of mercury. If more pressures are used, then cornu opens up and then this malignant material can go into the peritoneal cavity. Ultimately, endometrial hyperplasia is always diagnosed on the basis of only histology. So, if previously the pathologist used to give report of simple hyperplasia, complex hyperplasia, atypical hyperplasia, but since WHO has given guidelines in 2014 that it has to be only given as hyperplasia without atypia or with atypia. Why it is important to have differentiation that is without atypia and with atypia is because the revised classification says hyperplasia without atypia has less than 1% coexisting invasive endometrial cancer, and with atypical hyperplasia there can be a coexistent 25 to 33% chances of endometrial cancer in these patients. So you should advise your pathologist to diagnose it and give it only in this format, whether it's without atypia and with atypia. So after this histological diagnosis or reports comes to you, is it challenging to treat endometrial hyperplasia? Because sometimes a pathologist can give you different reports. Cystic, simple, complex. We have to know and we have to have a definitive approach for the treatment of endometrial hyperplasia. And it has been revolutionized in late 1980s by use of transvaginal sonography and then hysteroscopy, and now since last 10 to 15 years, LNG IUDs have really benefited these patients of endometrial hyperplasia. Before going to the treatment, the mainstream of the management is counseling is desirable. Complete information of the problem with the documentation, information about length of treatment, possible side effects, efficacy of treatment, and the most important is possibility of recurrence and if surgical options if therapy fails. Sometimes with the endometrial hyperplasia without atypia, observation alone is a treatment. Spontaneous regression is possible in endometrial hyperplasia without atypia. Chances of relapse to be considered and follow-up is essential in high-risk factors. What are the high-risk factors? Again, obesity, early menarche, late menopause, prolonged annulation, or PCOS patient. These are the high-risk factors. But if present, should change the management strategy and opt for medical therapy. What is the medical therapy in endometrial hyperplasia without OTP? Progestrogens, and progestrogens. But whether to give continuous therapy, cyclical therapy, or LNG-IUS, because there are regression, relapse, so you have to make a choice of progestrogens which you are using, which is a mainstay of treatment of unrelated bleeding, and which is a 50% total prescribed drug. It has anti-mitotic effect on endometrium. They stimulate 17-beta hydroxysteroid dehydrogenase and sulfotransferase activity, which convert estradiol to estrone sulfate. They inhibit estrogen induction of its own receptor and suppress estrogen-mediated transcription of oncogens, which induces endometrial atrophy and prevents proliferation of endometrium. So progestrogen is going to act on the stroma. Progestrogens, what are the drugs which are available? Either you can use norethistron, medroxyprogesterone. They can be given from day 5 to day 25 of the cycle, which causes significant reduction of the flow. If patient has acute bleeding, then they can be used as high as 30 milligram per day norethistron. Emergency drug can be used as 15 to 20 milligram per day. And once bleeding is controlled, then they can be given in a dose of 10 milligram per day for a longer time. It has slight side effects like mood changes, fatigue and weight gain, headache, but that can be tolerated. The important drug which has come into market and which has revolutionized the treatment of endometrial hyperplasia is LNG-IUS, which is a long-acting reversible therapy which releases the progesterone levonorgestrel at around 20 microgram per day. It has suppressive effect on endometrial growth. After a few weeks of insertion, endometrial glands atrophy, stroma becomes swollen, and the mucosa thins out and epithelium becomes inactive, described by Perino et al. As cylindrico-cubic monostratified without mitosis. Inflammatory reaction characterized by increase in neutrophil, lymphocyte, plasma cells, and macrophages is being described by Zhu et al. Vascular changes include a thickening of arterial walls, suppression of spiral arterioles, and capillary thrombosis. So, endometrium becomes unresponsive to the estrogen. There is no change in factor VIII, and number of bleeding days are decreased by 60% in these patients. As you can see here, in first 0 to 3 months, there is a much spotting which progressively decreases. 3 to 6 months, less spotting and less flow in the menstrual blood. And after 6 months, even amenorrhea in 20% of the cases, or other patients, there is an oligomenorrhea. According to the ACOG 2010, a systemic review found that LNG system is effective treatment for hyperplasia without atypia. The regression rate is almost 96%, but accurate diagnosis and ongoing surveillance are essential part. Why we should choose LNG-IUS is because it's an office procedure, good alternative to hysterectomy, reversible, saves money and time because progesterone therapy monthly, daily is going to cost more. The most important is satisfaction and improvement in the quality of life and acceptance and avoidance of operative treatment by the patients. There's always a question, how can I treat an endometrial hyperplasia in the best possible way, and can I be in a safe zone? Can I be treating endometrial hyperplasia based on evidence? So for that, we are going to talk next 10 minutes about management of endometrial hyperplasia by Green TOG Guidelines number 67, which has come in February 2016. As you know, grades of recommendation: A is the best, B is okay, C is okay, and D is not good so much. 1++, 1+, and 1+. So now we are going to coming to the RCOG guidelines. How should endometrial hyperplasia without atypia be managed? And what should be the initial management of hyperplasia without atypia? These women should be informed the risk of endometrial hyperplasia without atypia progressing to cancer is less than 5% over next 20 years, and that majority of cases of endometrial hyperplasia without atypia will regress spontaneously during follow-up. Level B evidence. Reversible risk factors such as obesity and use of HRT should be identified and addressed if possible. Observation alone with follow-up endometrial biopsies to ensure disease regression can be considered, especially when identifiable risk factors can be reversed. However, these women should be informed that treatment with progestrogens has higher disease regression rate as compared to observation alone. Progesterone is indicated in women who fail to regress following observation alone and in symptomatic women with abnormal uterine bleeding. Now comes question, what should be the first line medical treatment of hyperplasia without atypia B? Both continuous oral and local progestrogens are effective in achieving regression of endometrial hyperplasia without atypia, that is level A evidence. LNG IUS should be the first line of medical treatment because compared with the oral progestrogens, it has a higher disease regression rate with a more favorable bleeding profile and is associated with a fewer adverse effect. Again, level A evidence. Continuous progestrogen should be used for women who decline the LNG IUS. That means those women who are not comfortable with the IUDs or those who are not able to have a follow-up from villages. This is level B evidence. And cyclical progestrogen should not be used because they are less effective in inducing regression of endometrial hyperplasia without atypia compared with continuous oral progestrogens or LNG-IUS, that is level A evidence. So no cyclical progestrogens should be used for this because they are less effective. What should be the duration of treatment and follow-up of hyperplasia? Treatment with oral progestrogens or LNG-IUS should be for minimum 6 months in order to induce histological regression of endometrial hyperplasia without atypia, that is level B evidence. Endometrial surveillance incorporating outpatient endometrial biopsy is recommended after a diagnosis of hyperplasia without atypia, that is level C evidence. Now the question remains to you, this patient is coming to you again and again. When is surgical management appropriate for this patient with endometrial hyperplasia without atypia? Hysterectomy should not be considered as first-line treatment in cases without atypia because progesterone therapy induces histological and symptomatic remission in the majority of women, which you can avoid morbidity associated with major surgery. When atypia, 96% is the regression rate, so no need of surgical treatment in the cases of women with endometrial hyperplasia without atypia. So that is been concluded, but it is a level C evidence. Hysterectomy is indicated if progression to atypical hyperplasia occurs during your follow-up periods. There is no historical regression of hyperplasia despite you are given a treatment of 12 months. There is persistence of bleeding symptoms in the patients in spite of a LNG-IUS or progesterone therapy. The woman declines to undergo surveillance or comply with the medical treatment. Here you can do a hysterectomy, but it is a level C evidence. Postmenopausal women requiring surgical management for endometrial hyperplasia without atypia should be offered bilateral salpingo-oophorectomy together with the total hysterectomy. For premenopausal women, the decision to remove the ovary should be individualized. However, bilateral salpingectomy should be considered as this may reduce the risk of future ovarian malignancy. Very important, level D evidence. A laparoscopic approach to total hysterectomy is preferable to an abdominal approach as it is associated with shorter hospital stay, less post-op pain, and quicker recovery. Level B evidence. The most important is endometrial ablation is not recommended for the treatment of endometrial hyperplasia because complete and persistent endometrial destruction cannot be ensured, and intrauterine adhesion formation may preclude future endometrial histological surveillance, which is to be done for this patient. Now, how should that was for the patient without atypia. Now, coming to the most important part, how should atypical hyperplasia should be managed? What should be the initial management? Women with atypical hyperplasia should undergo a total hysterectomy because of the risk of underlying malignancy or progression to cancer level B evidence. Laparoscopic approach appears to be better than open approach. There is no benefit from intraoperative frozen section analysis of endometrium or routine lymphadenectomy. Very important. These are the patients of atypia and not malignancy. You have diagnosed it with a histology. There is no need of doing a lymph node dissection, pelvic lymph node dissection, or intraoperative frozen pelvis. Frozen section is not required for these patients. Don't waste money on that. Postmenopausal women with atypical hyperplasia should be offered bilateral salpingo-oophorectomy together with a total hysterectomy. So these are the indications for atypical hyperplasia. Now, how should a woman with atypical hyperplasia who wish to preserve their fertility or who are not suitable for surgery should be managed? Most of the time, as I told you, obesity, PCOD, prolonged anovulation, these are the patients with infertility. So they say, no, I want a pregnancy. I cannot undergo hysterectomy only on the report of atypia. I don't have a cancer. So these are the patients who needs to counsel properly, and you should tell them about the risk of underlying malignancy and subsequent progression to endometrial cancer. Pretreatment investigations should be aimed to rule out invasive endometrial cancer or coexisting ovarian cancer. Histology, imaging together, and tumor marker should be reviewed in multidisciplinary meeting. Though tumor markers are not diagnostic in a case of CA endometrium, histology and imaging are important. And the first line treatment is with LNG IUS with oral progestins as second best alternative for this patient also. So now, how should a woman with atypical hyperplasia not going hysterectomy to be followed up? Routine endometrial surveillance should include endometrial biopsy. Review schedule should be individualized and be responsive to the changes in woman's clinical condition. Review interval should be every 3 months until 2 consecutive negative biopsies are obtained. These are the patients who are very important. Those patients where LNG IUS is already fitted in, we feel how to take a biopsy. This pipelle is a small which goes inside along the side of LNG IUS, and you can take a biopsy with the pipelle. It is not very difficult and it is done routinely. So don't worry, even if LNG IUS is there, by side you can take a biopsy for these patients. In asymptomatic women with the uterus and evidence of histological disease regression, based upon a minimum of 2 consecutive negative biopsies, long-term follow-up with endometrial biopsy every 6 to 12 months is recommended until her hysterectomy is performed. Now, this patient, as I told you, wants to conceive. What are the guidelines which says? Disease regression should be achieved on at least 1 endometrial sample before these women attempt to conceive. Women with endometrial hyperplasia who wish to conceive should be referred to fertility specialists to discuss options for attempting IVF or conception, further assessment and appropriate treatment. Assisted reproduction may be important in this patient because the success rate of assisted reproduction is fast than routine treatment, and regression of endometrial hyperplasia should be achieved as this is associated with higher implantation and clinical pregnancy rate. Now we have discussed about without atypia, with atypia, hysterectomy, those who wants to conceive. Now the last part comes HRT and endometrial hyperplasia. Systemic estrogen only HRT should not be used in these patients. Level A evidence. A woman taking HRT should be encouraged to report any unscheduled vaginal bleeding promptly. And women with endometrial hyperplasia taking sequential HRT preparation who wish to continue HRT should be advised to change to continuous progesterone intake using LNG IUS or continuous combined HRT preparation. Subsequent management should be as described by preceding sections of the guideline. Women with hyperplasia taking continuous combined preparation who wish to continue HRT should have their need to continue HRT reviewed again. Discuss the limitation and available evidence regarding optimal progesterone regime in the contest. Consider using LNG IUS as a source of progesterone replacement, and subsequent management depending on the guideline has to be done. Now, how should be these women manage on adjuvant treatment for breast cancer? What is the risk of developing endometrial hyperplasia on adjuvant treatment for breast cancer? Those women who are taking tamoxifen should be informed about the increased risk of developing endometrial hyperplasia and cancer. They should be encouraged to report any abnormal vaginal bleeding or discharge promptly. There is evidence that the LNG IUS prevents polyp formation and that it reduces the incidence of endometrial hyperplasia in women on tamoxifen. The effect of LNG IUS on breast cancer recurrence risk remains uncertain, so its routine use cannot be recommended those patients who are on tamoxifen. How should a woman who develop endometrial hyperplasia while on tamoxifen treatment for breast cancer to be managed? The need of tamoxifen should be reassessed again, and management should be depending on histological classification of endometrial hyperplasia and in conjunction with the women's oncologist. That is very important. How should a polyp in endometrial hyperplasia to be managed? Complete removal of uterine polyp is recommended, and also an endometrial biopsy should be obtained to the sample of the background endometrium. To finish off, algorithm is endometrial hyperplasia without atypia, address the risk factor, observation, LNGIS as first line, oral progesterone second line, atypical hyperplasia, always hysterectomy. If she requires fertility, then again go to the endometrial hyperplasia without atypia, do her biopsies, minimum 2 biopsies has to come negative, give this patient a therapy of progestagens. It can regress, persistent or progression. If regression, then review treatment. LNG IUS for 5 years is better. If persistence is there, review the treatment, start medical treatment if observation fail, and advise hysterectomy for this patient. If region is progressing, always better to go for a hysterectomy. So how to arrange follow-up? BMI less than 35 or more than 2 consecutive negative endometrial biopsies at 6-month interval, then discharge. BMI more than 35 treated with oral progestagens, more than 2 consecutive negative endometrial biopsies at 6-month interval. Thereafter, this patient can go for an annual endometrial biopsy. And 2 consecutive negative endometrial biopsies at 3 months interval. Thereafter, 6 to 12 monthly endometrial biopsies can be done. And you have to review these. If any time there is a relapse, this patient is for a hysterectomy. These are the risk factors: obesity, HRT regime, tamoxifen therapy, and those patients with chronic annulation. Take home message for endometrial hyperplasia: continue endometrial surveillance, which is mandatory. Counseling is essential part. What are the current guidelines? Is investigate with TVS, color Doppler, do histology, divide into without atypia or with atypia, depending on age, parity, and risk factor. Choose progestagens, LNG over orals. Try for continuous 6 months. If with atypia, with completed family, go for a hysterectomy. Follow-up is mandatory for those patients where hysterectomy is not done. In selected cases, progesterone in high doses for 3 to 6 months can be given. Counseling is very important. Endometrial hyperplasia with atypia relapse, go for a hysterectomy. No need of doing a lymphadenectomy. Endometrial hyperplasia with atypia, endometrial biopsy to be repeated 6 monthly for close monitoring. Endometrial ablation not recommended because complete destruction is not achieved. Special category with atypia, those who are desirous of pregnancy, LNG device for 6 months. Regression is possible to enable them for fertility treatment. Minimum 2 endometrial biopsies has to come negative. And lastly, endometrial hyperplasia without atypia, LNG IUS is a first-line therapy. If it is contraindicated, progestins can be used for this patient. When you can do a hysterectomy in a case of endometrial hyperplasia without atypia, preventive hysterectomy in an extremely obese patient without any prospect of weight loss, or those patients who have persistent bleeding in spite of progestogen therapy. Laparoscopic, vaginal or abdominal, whichever route is you are doing is good. Do it without or with oophorectomy depending on her age, but salpingectomy is must because it is going to prevent ovarian carcinoma. So this is the last AUBM, endometrial hyperplasia management. You can click the picture because that is very important diagnosis depending on WHO classification. I'm really thankful again to, thank you so much, Dr. Pratik Tambe, for giving me this opportunity. And thank you, Dr. Pardisi sir, Dr. Malaraj, for giving this opportunity. Thank you so much.
Thank you, Dr. Kalyan. Kalyan has elaborated very nicely this topic. As all the aspects he explained, diagnosis is very important, and as he told, TVS is gold standard in diagnosis. Role of sonography in all is important, and hysteroscopy is at most important. I think hysteroscopy and laparoscopy is the topic of Kalyan. And he told endometrium is really a challenge in the treatment and management, where he explained all the modalities, hormonal treatment, then medicinal, and even use of LNG and algorithm. Lastly, he explained very nicely. Thank you so much, Dr. Kalyan. Dr. Mala, would you like to comment? Dr. Mala? Hello, Dr. Mala?
I think she has some network issues, sir. With your permission, we'll move to the second speaker. Dr. Biswajyoti Guha, sir, has logged in. And I would request Dr. Sujata Dalvi, ma'am, to please do the honors and introduce sir. We'll do the Q&A together for both the speakers at the end of the second speaker.
Thank you.
Thank you, Dr. Pratik. At an outset, I would like to thank the organizers, especially the AMOG's president, Dr. Nandita Palshetkar, and today's AMOG's seminar convener, Dr. Pratik Tambe, who is also the chairperson of AMOG's endocrine committee. And we have our next speaker, Dr. Biswajyoti Guha, and he is going to be speaking on modern management of Rh negative pregnancies. Now, Dr. Biswajyoti Guha is a consultant obstetrician and gynecologist at Amri Hospital, Mukundapur. He is also a consultant obstetrician and gynecologist at Bhagirathi Nyota Hospital, Newtown. He's been the joint secretary of Bengal Obstetrics and Gynec Society. He's a council member of AICC RCOG East Zone. He's an honorary secretary of ISOPAR, Kolkata chapter, and he's also been a clinical examiner for MRCOG Part 3. So over to Dr. Guha for management of Rh negative mothers.
Thank you very much, Dr. Dalvi, for such a nice presentation. And thank you very much, Dr. Pratik, for inviting me in this, and the entire team, AMOGs, for inviting me for this talk today. It was a very hurriedly prepared talk because Dr. Pratik told me just on Sunday. And in spite of a busy schedule today, I thought I will give him some time. He's a very good friend of mine. So can I share my screen, please?
It's always pleasure to have different speakers from different zones over India.
Thank you very much, ma'am. It's very, very kind of you for inviting me. Thank you so much. So my talk today is about management of Rh negative pregnancy, which probably we all have to encounter in our day-to-day practice. And I again thank the entire team AMOGs and Dr. Pratik Tambe for inviting me for this talk. I'm really grateful to them. And today, my management of ectopia, my management of Rh negative pregnancy will have a small outline, which is an introduction. We will discuss a little bit of epidemiology, some bit of pathology, pathophysiology of Rh negative pregnancies, management, problems in our setting, some recommendations, and of course, we will end the talk by some conclusions and some take-home messages. So prior to the availability of anti-D immunoglobulin, the incidence of allo and alloimmunization in D negative women following 2 deliveries of D positive AVO compatible infants was approximately 16%. And hemolytic disease of the fetus and newborn due to anti-D was a significant cause of morbidity and mortality. And following the routine postpartum administration, so I am dividing it into before, postpartum, and routine antenatal. So routine postpartum administration of anti-D IgG, the rate of alloimmunization dropped to approximately 2%, and a further reduction in the sensitization ranging from 0.17 to 0.28% was achieved by introducing routine antenatal prophylaxis during the 3rd trimester of pregnancy. So these are findings that has actually removed the curse of Rh negative women and Rh negative women having HDFN pregnancies, and this is one of an Rh alloimmunized pregnancies, and this is one of the very important, I think one of the most important achievements of modern science in this 21st century. And also it is associated with this reduction in sensitization is a reduction in mortality associated with HDN from 46 per 100,000 live births to 1 to 1.6 per 100,000 births. So this is how RAADP has changed our practice. And these findings contributed to the NICE recommendation that all D negative pregnant women who do not have immune anti-D should be offered additional routine prophylaxis with anti-D IgG during the 3rd trimester of pregnancy. So what about epidemiology? Does epidemiology matter? Of course it matters, because globally the Basque population of Spain has the highest incidence of Rh negativity. So it is around 30 to 35%. Otherwise, whites is around 15 to 16%. African Americans is about 8%. Black Africans 4%, and Asians and others are 2% or less. And let me tell you that even some atypical antibodies that are present in the blood have different regions where their incidences are much more. For example, in West Bengal, if we go to North Bengal, we have a high incidence of K-cell antibodies. And Nigerian studies, there is 4.5% prevalence rates of Enugu in southwest, 0.7% incidence rate at Kaduma in north, and 5.5% prevalence rate at Ogbomoso in southwest. So what about the pathological systems? This is something that we all know, that there are 2 basic blood group classification we have, which is the ABO system and the RH system. And our ABO system, we group them as AB, O antigen, and the RH system as C, small c, capital D, E, and small e, and G. DG, that represents the big DG, the capital DG, and the D antigen is considered to be the most immunogenic. And the amount of fetal blood necessary to produce Rh incompatibility varies, but it is as little as 0.1 mils of Rh positive cells have been documented. Studies have suggested that up to 30% of persons with Rh negative blood never develop Rh incompatibility even when challenged with large volumes of Rh positive bloods. And Rh alloimmunization occurs by one of 2 mechanisms, which is after an incompatible blood transfusion and after fetal-maternal hemorrhage, where we are going to concentrate our talk on. Fetal-maternal hemorrhage may occur during pregnancy or during delivery, and during pregnancy the incidence is less, which is about 10%, and during delivery it comes to about 90%. Notwithstanding, fetal RBCs have been detected in the maternal blood in all 3 trimesters without an apparent predisposing factor. So there goes the risk of fetal-maternal hemorrhage. And the initial maternal response to Rh sensitization is low levels of immunoglobulins IgM antibodies. These are confined to maternal circulations, being unable to cross the placental barrier. Within 6 weeks to 6 months, what happens is IgG antibodies are formed. These are able to cross the placenta and destroy the fetal Rh positive cells, and therefore the first-born infants with Rh positive blood type are not affected. The short period of first exposure of mother to fetal RBC is insufficient for production of significant IgG antibody response unless it occurs very early in pregnancy. So what about hemolytic disease of the newborn? It is a sequence of in utero events. Maternal IgG enters the fetal circulation via placenta, it destroys the fetal red cell and causing fetal anemia. Heme is formed and converted to bilirubin, which results in fetal hyperbilirubinemia or jaundice. Both are neurotoxic but effectively cleared by placenta and metabolized by the mother. Extramedullary erythropoiesis is stimulated and immature erythroblasts are produced. When cell destruction exceeds production, severe anemia occurs. More demand on the extramedullary sites to produce more red cells. There is hepatosplenomegaly, and in the end, there is a heart failure with ascites, edema, and pericardial effusion, which we traditionally used to call erythroblastosis fetalis. And hydrops fetalis occurs when the hematocrit falls below 15%, often results in fetal death shortly before or after birth. And there is a male to female fetus ratio, and males unfortunately are much more prone to develop it, 13.1 to 1 female fetus. So the risk and severity of sensitization response increases with each subsequent pregnancy involving an ABO compatible fetus with Rh positive blood. Without prophylaxis, this risk is 16% after 2 deliveries, 1.5 to 2% occur antepartum, 7% within 6 months of delivery, and 7% manifest early in the second pregnancy. With prophylaxis, when we do routine antenatal RAADP rather, the risk drops to 0.1%. So we can understand how important RAADP is for Rh negative women. Rh sensitization risk, the aforementioned risk depends on 3 main factors. The volume of transplacental hemorrhage, so that is very important. Extent of maternal immune response, how the mother's immune system is responding to that amount of hemorrhage, and concurrent pregnancy of ABO incompatibility, protective risk drops to 1.5 to 2%. Rh incompatibility is only of medical concern for females who are pregnant or plan to get pregnant in the near future. History for potentially sensitizing events are abortion, which we know, invasive procedures such as amniocentesis, chorionic villus sampling, abdominal or pelvic trauma, antepartum hemorrhage, which might be a placenta previa or an abruption, intrauterine fetal demise, if there is multiple gestation, if there is manual removal of the placenta, ectopic pregnancy, and cesarean delivery. And other aspects of history to be explored include whether this lady had a prior blood transfusion or not, whether what about the Rh blood type of the patient and the spouse, all previous pregnancy outcomes and intervention, whether there is a history of hydros because it has got a 90% chance of recurrence, previous administration of Rh in immunoglobulin, mechanism of injury in cases of maternal trauma during pregnancy, presence of any vaginal bleeding, and prior invasive procedures. The objective of antenatal management is prevention of Rh alloimmunization in the Rh negative unsensitized women. So if the woman is already sensitized, I am unfortunately this RADP is not going to do any good to that woman. Early detection and treatment of fetal anemia in the sensitized women, and sensitization is determined by indirect Coombs test, otherwise called the antibody screen. So what are the types of antibodies, or what are the timings of the antibody screen that we do? So if the mother is Rh negative and the father is Rh positive, we routinely require an antibody screen at 20, 24 and 28 weeks, which we will go later on and see what the British Society of Hematology has to say about it. If it is negative, then we give them 300 microgram of immunoglobulins at 28 weeks. At delivery of the baby, the Rh status of the newborn is to be checked again. If the baby is Rh negative, no further treatment is required. If the baby is Rh positive, then we administer another 300 microgram of anti-D within 72 hours of delivery. If, however, this antibody screen turns out to be positive, then it has to be managed as an Rh sensitized pregnancy. Amniocentesis may be done for estimation of fetal bilirubin levels. Optical density at 40 nm we has to be is one of the things that we go by, And further management based on fetal condition is determined by percutaneous umbilical blood sampling, amniotic fluid analysis, ultrasound examination, and Doppler ultrasound of the middle cerebral artery, which we will come in a short while from now. So management depends on precautions. What are the extra precautions that we need to take during delivery of an Rh negative mother? We must ensure that your neonatologist is in the loop. Don't give oxytocics at the delivery of anterior shoulder. If manual removal of placenta is required, it has to be done very gently. If blood transfusion is indicated, only Rh negative group specific blood only has to be transfused. Early clamping of umbilical cord is indicated, and also try to leave. We must leave a cord, a long length of cord for cordocentesis if required, which may be about 15 to 20 centimeters. So this is a very important aspect that we must involve the neonatologist beforehand, because he is one of the persons who is going to take care of the baby. And if you make him aware about the Rh status of the lady, then he or she will be much more equipped to deal with this particular case. And again, in the postpartum management, a neonatologist need to be in the loop always. Send cord samples for ABO Rh typing, direct Coombs test, a hemoglobin and a bilirubin level, and sometimes a peripheral smear if required. If fetus is Rh negative, we do not do any other further investigations because there is no risk of sensitization. If fetus is positive, determine the dose of Rh IgG to be administered by a 4-step laboratory procedure. So this is this 4-step laboratory procedure means rosette fetal RBC screen for FMH if positive, acid elution test to quantify the RBCs in maternal circulation, estimate the volume of FMH by calculating 50 into the percentage of fetal RBCs, calculate the dose of Rh immunoglobulin to be given within 72 hours of delivery. So this is a negative rosette test where we can see there is no clumping. However, a positive rosette test means there are clumping and hemolysis, and this is the acid dilution test. For sensitized women, management is guided by following: presence or absence of history or affected fetus in previous pregnancy, example with severe anemia or eye drops, maternal antibody titers where no prior history is obtained, and sensitization may be determined by doing an antibody screen using indirect Coombs test. So this is the direct Coombs test that we are talking about, that the blood sample from a patient with immune-mediated hemolytic anemia, antibodies are shown to be attached to antigens on the RBC surface. The patient's washed RBCs are incubated with anti-human antibodies, and RBCs agglutinate anti-human antibodies form links between RBCs by binding to human antibodies to the RBC. And indirect Coombs test is just a reverse of what we talked about. Recipient's serum is obtained containing antibodies. Donor's blood sample is added to the tube with the serum. Recipient's immunoglobulins that target the donor red blood cells form antibody antigen complexes. Anti-human immunoglobulins are added to the solution, and the positive test result in agglutination of red cell blood cells occurs because human immunoglobulins are attached to red blood cells. So management of sensitized Rh negative women: no previous history of affected fetus, obtain ABO and Rh group of husband. If positive, obtain antibody titer. If antibody titer is below the critical level by 36th week, continue pregnancy to term, but do not allow it to get post-dated. If antibody titer is beyond critical level after 34th week, deliver immediately. If antibody titer is beyond the critical level before 34th week, further testing, we do it by the peak systolic velocity of middle cerebral arteries of using Doppler, amniocentesis for analysis and spectrometry, ultrasound examination, which basically is middle cerebral artery Doppler, and percutaneous umbilical cord blood sampling for hematocrit and Rh. And if there is a previous history of sensitization, establish sensitization, cordocentesis for determining fetal hematocrit, Rh genotype, amniocentesis for amniotic fluid, spectrophotometry and assay, and initiate middle cerebral artery surveillance from 18 weeks onwards. So what about fetal assessment of hemolysis and invasive procedure? amniocentesis and checking of optical density 450 to check level of bilirubin in amniotic fluid, and fetal blood sampling and checking fetal hemoglobin levels. So we already talked about this potentially sensitizing events in pregnancy, which are amniocentesis, CVS, antepartum hemorrhage, external cephalic version, abdominal trauma, ectopic pregnancy, evacuation of molar pregnancy, in utero therapeutic interventions, miscarriage, therapeutic termination of pregnancy, delivery, which may be normal or cesarean or instrumental, and intraoperative cell salvage. So management of sensitized fetus is usually by the middle cerebral artery Doppler. We usually go by the middle cerebral artery Doppler indexes. Not useful before 18 weeks of gestation. RES is too immature to hemolyze enough cells to cause significant anemia. Not a reliable predictor of severe anemia after 35 weeks, and found to be similar or better than amniotic fluid of optical density 450 in prediction of anemia. So this is how a normal versus abnormal MCF, PC, PSV looks like. And the management will differ. The management will be according to the results of MCAD velocimetry, unaffected, mildly affected fetus, normal MCAD, Doppler is repeated monthly, deliver at or near term after lung maturity, low risk of intrauterine fetal death. Moderately affected, we must see the middle cerebral artery Doppler about 1.5. It is about 1.5 multiples of median. Repeat 1 to 2 weekly. If the lung is mature, we have to deliver, and we might need to enhance lung maturity if necessary by antenatal corticosteroids. And if it's severely affected or has frank evidence of fetal height drops, fetus needs to help to attain lung maturity before delivery, and there is a high risk of intrauterine fetal death. And this is the traditional spectrophotometric chart that we used to go by, the Lylis chart, which is not accurate before 26 weeks of gestation, and the Queenan chart, which is a little bit more advanced and can be used from 14 to 48 week of gestation. Sensitivity is 10% superior to Lylis curve. So what about continuing with the management? If MCA Doppler peak systolic velocity, MCA PSV 1.5 MOMs and above, fetal blood sampling and consider intrauterine transfusion. If no facilities for fetal blood sampling or amniocentesis, then we have to transfer it to a tertiary care center. And if MCA PSV less than 1.5 moles, monitor MCA PSV 1 to 2 weekly. Intrauterine blood transfusion is recommended treatment for severe hemolytic anemia in utero, typically carried out between 18 and 35 weeks of gestation, may be given either by the intraperitoneal or intravascular route. ORHD negative packed cells with hematocrit of 80% is used, and amount is to be transfused in milliliter is calculated by the gestational age into 10, where gestation is greater than 20 weeks. And basically, this is how it is carried on. The sensitive Rh negative women, what about the management of this kind of ladies? Postpartum management of the neonate, baby if alive should be admitted into neonatal intensive care unit, and urgent exchange transfusion is indicated in moderate to severely affected neonates, and phototherapy for mild affections is all that is required. What about the special fetomaternal weak states? If there is an abortion, up to 50% chance, 5% chance of sensitization, 50 microgram of anti-D is recommended. Invasive fetal procedure, up to 11% chance of sensitization, 300 microgram is recommended. Antepartum hemorrhage, 300 microgram is given stat, to be repeated at 12 weeks later if pregnancy lasts that long. An external cephalic version, the chances is about 6% of sensitization, and dose is 300 microgram. And delivery, what about delivery with fetomaternal hemorrhage? The normal amount of fetal blood that enters the maternal circulation is 0.5%, 5 milliliter. Dose of RH immunoglobulin given is 300 microgram, will neutralize nearly 30 milliliter of whole fetal blood. Management is guided by estimated volume of FMH determined by the 4-step lab test, and dose of RH immunoglobulin given after sensitization is at least 20 microgram per milliliter of fetal RBCs. So what are the recent advances in this in RH IC immunization? Non-invasive fetal RHD genotyping can be done from free FFN, that is free fetal DNA in maternal circulation, point of care test, that is rapid test for determining RH status, a lower and 50 microgram dose preparation of RH immunoglobulin for use following first trimester abortions, which is now available in the market and has been available for quite a long time. Concept of partial D and weak D antigens usually test positive but can also form anti-RH antibodies. So take-home points are every woman of childbearing age should have her ABO and RH typing done at first contact. Obtain the ABO RH types of husbands of women found to be RH negative. Ensure ICT is done at 20, 24 and 28 weeks of pregnancy with appropriate prophylaxis. And a single postpartum dose may be inadequate in cases of severe hemorrhage. High cost of immunoglobulin is a problem in our settings. Lack of resources to adequately investigate and monitor fetus in utero. Low turnout for antenatal clinics and missed cases. Poor documentation of prior sensitizing events. Some are yet to fully grasp the import, and loss of case notes. Research illumination is a real problem, and real efforts needs to be made to mitigate its impact. Although its incidence has decreased dramatically, yet the consequences of hemolytic disease of the newborn remain, and great advancements have been made in detection and management of this condition, and many of our RH negative women can now have a happy obstetric career. But before we end, I am going to show you this anti-D administration checklist, which is a potentially sensitive events during pregnancy. So if it is a vaginal bleeding associated with severe pain, if there is an ERPC done, if there is a medical or surgical termination of pregnancy or ectopic or molar pregnancy, administer at least 250 IU of anti-DG within 72 hours of the event, and confirm product expiry and patent, that is we all know. Gestation 12 to 20 weeks for any potentially sensitizing events, administer at least 250 IU of anti-Ds. Gestation 20 weeks to term, it's 500 IU within 72 hours of the event, and confirm product dose expiry, that is we need to know. And does the Clay-Howard and the FMH test indicate that further anti-IgG is required? If it is required, then we have to administer more anti-D IgG following discussion with the labs. And routine anti-D prophylaxis, which we are vocal about nowadays. For routine anti-D prophylaxis, irrespective of whether anti-D already given for PSC, take blood sample to confirm group and check antibody screen. Do not wait for results before administering anti-D IgG. Administer 1500 IU anti-D at 28 to 30 weeks. Administer at least 500 IU anti-D at 28 weeks, and then administer at least 500 IU anti-D at 34 weeks. And at delivery or on diagnosis of intrauterine fetal death greater than 20 weeks, request a Clay-Howard count. Administer at least 500 IU anti-D IgG within 20 to 72 hours of delivery. And if the Clay-Howard test done that we need more doses of anti-D, then we have to prescribe accordingly. So at booking, all pregnant women must have an antibody screen, clinically significant antibody screen, positive anti-D, C or K antibodies test monthly until 28 weeks. All other clinically significant antibody consider paternal fraternal genotyping for corresponding antigens. From 28 weeks takes 2 weekly until delivery. Repeat antibody screen at 28 weeks and cord blood for DAT, hemoglobin and bilirubin. No clinically significant antibodies, repeat test at 28 weeks. If there are no antibodies, no further action. However, if there is a clinically significant antibodies, then we have to manage it accordingly. So this is the management algorithm for pregnancy. Is complicated with anti-D, anti-K or anti-C alloimmunization. I'm not going to go through this slide now. It is available on the RCOG Green Top guidelines. And I must thank you all again for inviting me for this talk, and special thanks to Dr. Pratik Tambe, who has been a very good friend of mine and has compelled me to do this talk today virtually. Thank you very much. I hope that I have been clear to you all. Thank you very much.
So thank you, Dr. Guha, for such a nice deliberation that you elaborated how to prevent RHIC immunization, because nowadays incidence of RHIC immunization is much less as what we used to see when we were residents. But in case you do find a patient with RHIC immunization, how to go about managing these patients is also very important. One thing is, even after medical abortions, if patient is Rh negative, she needs to take a Rh anti-D injections even after a medical abortion, or if she has had a threatened abortion in the first trimester also, it's always advisable to give her anti-D injections. Okay?
Exactly.
Yeah,
Thank you.
yeah. I would request Dr. Mala Rai, she's been able to join it, so in case she wants to contribute something.
Hello, Dr. Raj.
Dr. Rajendra
Yeah, good afternoon, everybody. Extremely sorry. I don't know. It has never happened. Has such an unstable internet connection today. I'm extremely sorry about the whole thing. Okay, so this is an excellent program, in fact, and I would like to thank Dr. Pratik Tambe for giving me this opportunity. Of course, second half I was able to listen. And of course, Sir Guha's talk also was very good. So I would like to know, like, suppose if the patient has been already immunized after the first pregnancy, is there any role for prophylactic anti-D in the first trimester in the succeeding pregnancies?
See, if the pregnancy has already been sensitized, then we would recommend not to give anti-D prophylaxis, because now your pregnancy management will be completely different from what it was last time. But yes, I would agree with you that in some cases, because there are various types of anti-Ds, there are various types of antibodies such as the anti-D, anti-C, K, or the minor types. So it might not be prudent to give her routine anti-D prophylaxis also.
Yeah, okay, so thank you. Then I would also like to know, there are many instances like, now that it is rampant that people get to do this medical abortions all by themselves, looking at the internet. So where they don't have any clue as to what their blood group is also. So when they come to us with a history saying that they had a medical abortion, which they got it done by themselves, and if we happen to see a negative group in them. So in this succeeding pregnancy, how are you going to manage? Do you give anti-D as a precautionary in these women who have already gone through a medical abortion and they have been negative and not been immunized?
You have to do Rh antibody titer when these patients come. Sorry, Dr. Gu, I thought. Yeah, you have to do Rh antibody titer when they come to you in the next pregnancy and find out if antibody titer is negative, you treat her as a routine patient. But in case she's positive, it means that she has been sensitized previously when she had taken medical abortion pills, then you treat her as a sensitized person. And that's how you go about it.
Yeah, that's all. So we do the indirect home stress, and if it is...
Yes, everything like the same thing. And you give prophylactic dose only in the third trimester, around 28 to 30 weeks. We don't give it in the first or the second trimester.
Okay, sir. Thank you. Thank you, madam. And Dr. Kalyan Bamade, sorry, I was not there, but then a little bit I got to hear towards the end, little bits and pieces. Of course, it was excellent as usual and elaborate right from beginning to post-menopausal.
First time I got
everything. Dr. Kalyan.
No, I was...
Pardon?
No, I must say that I really enjoyed Dr. Kalyan Barmade's talk. It was really nice. It was
good, elaborated, good.
Yeah, this is all credit goes to Pratik sir, because he has given me 40 minutes time. Nobody in the world has given me so much time.
He makes everybody do the things,
Yeah. And my wife doesn't allow me to talk for so
long. Only one question, Dr. Kalyan. So if a postmenopausal woman who has an endometrial thickness of about 4 millimeters and she is totally asymptomatic, I mean more than 4 millimeters, postmenopausal women more than 4 millimeters, totally asymptomatic, endometrial thickness more than 4 millimeters. Do you?
Yeah, I got it. I got it. Those patients which are asymptomatic, postmenopausal, but beyond the cutoff of the endometrial hyperplasia, right?
Yeah.
So these are the patients where it is mandatory to do a endometrial biopsy at least once, once you are sure that it is atropic or whatever reason is to be found out, and once you are sure that there is no endometrial malignancy, then you can do a follow-up with ultrasound every 6 months for first two times, and then yearly a follow-up is required.
Yeah, correct. So there are a few questions I think here which has been posted from the delegates. What is the ET cutoff in case of perimenopausal women?
See, postmenopausal, as you know, 4 to 5 millimeter is a cutoff. In a premenopausal patient, if she's in a first phase of cycle, then it is, so many studies have shown that it is around 8 millimeter is okay in a proliferative phase. And in secretory phase, there are studies which have shown that around 12 millimeter is okay. So for any premenopausal age group, irrespective of her day, we should have a cutoff of around 10 millimeters. If it's more than that, then we should consider it as a endometrial hyperplasia, and you should start evaluating by doing a OPD procedure of endometrial biopsy.
Yeah, the RCOG guideline says that anything less than 7 millimeters in a TBS scan, it is less unlikely to be an endometrial hyperplasia. So if it is more than 7 mm, then maybe like say 8 millimeters.
Yeah, Dr. Mala, the largest study which is done by URAND, who has done a study of around 30,000 cases of TVS to rule out what is the criteria for endometrial malignancy, and he has found that in the cases of postmenopausal bleeding or without any symptom, if it is more than 5 millimeters, then it is going to be a problematic lesion. And in cases of premenopausal women, he has written this cutoff as around 10 to 12 millimeter.
Yeah,
depending on the phase of the cycle.
Right. So many a times there may be a concomitant endometrial carcinoma also along with this hyperplasia. So that is when we are in trouble. Like, so that is the reason hysteroscopy gives us a better
idea. Endometrial hyperplasia with a TPR is around 23 to 30% time, which is coexistent with the invasive malignancy of endometrium.
Yeah, fine. And I think there is one more question as to when exactly you need to do a hysteroscopy, whether it is going to be premenstrual or it is going to be postmenstrual.
So many times it is always better to do it between day 6 to day 10 or day 12 of the cycle. That is required because you already have a diagnosis of endometrial hyperplasia on ultrasonography. And if you want to do any operative procedure, it is always better to do in a first phase of cycle, that is between 6 to 9 days, than doing in a secretory phase where uterus is soft. Chances of perforation are more in this period. So I always prefer to do it in a proliferative phase.
In the proliferative phase. Okay, right, fine. Okay, so as you have clearly mentioned that in case of CA endometrium hysteroscopy, you have to be very careful. You have to set down the pressure to a little lower pressure because there is a chance of dissemination. I think that you have to keep it in mind unless, and I mean, if you have a full-blown case that is going to be a CA endometrium, you have to be very, very cautious. But many a times, you know, you can diagnose only at the time of a hysteroscopy. So you have to do the procedure very quick and, you know, come out.
That is why I said whenever you are in a doubt, please have lower pressures to start with the hysteroscopy. And once you are sure that it is a fibroid or it's a polyp, then you're not worried to increase the pressure. But around 70 millimeters of mercury pressure is maximum, wherein you can do the procedure because the studies have shown that more than these pressures, the osteas are going to open and this fluid can disseminate into the peritoneal cavity.
Yeah, most of this endometrial hyperplasia, if you see, they come with abnormal uterine bleeding. So they, in fact, they present to us quite early, like because the bleeding itself is literally driving them to us. So we need to evaluate them. In fact, also, adequately, like, in fact, you should not delay any further, like looking at the history. History plays a very major role so that all these hyperestrogenic conditions, you know, like the PCOS, all these endometriosis, they all have a similar presentations and fibroids. But then we also should have at the back of the mind, this hyperplasia always, like, of course, you have elaborated in depth. I am just trying to share a little bit of it. So that is very
the most worried patients for us are endometrial polyp with malignancy. These are the patients where it's very difficult.
Exactly.
You are thinking that it's a plain polyp and you are going to try your all, and your histopath comes to be a malignancy, then it is going to be a problem.
Yeah, especially when you have multiple polyps. Multiple polyps, invariably you think it could be some kind of endometritis like tuberculosis and all those things. That is when you are caught unaware, no? Like the reports come something else. Like
there is a dictum very well said by our seniors that when you are find multiple polypoid endometrium, don't do anything. Just put an MVA, manual vacuum aspiration pump inside. Remove all these polyps and send for histopathology.
Right.
Because so many times they may be benign, but there are chances of being, they can be a malignant, and you're going to spend a lot of time removing all these polyp and damaging the endometrial cavity.
Yeah, right, fine. So
can I say, sometimes we don't even go only on endometrial hyperplasia. If endometrium is irregular, and then if you do a color Doppler and if you find increased vascularity, irrespective of the thickness of endometrium, it is always better to put in a hysteroscope and do an endometrial biopsy. If it is an irregular endometrium, then we don't go on to the thickness as such, we just go on to the report and we do a biopsy.
Yes, ma'am. Transvaginal sonography plays a major role. When
Very major role. Absolute major role.
You find any irregular lesions, anything which is more than said cutoff point, then it's always better to
do it.
That's a guided biopsy.
So, are there any more questions?
No, I don't think we have any more questions. I would invite closing remarks from the chairpersons if there are no further points to be discussed.
So, ma'am, you can close.
No, Mala, you only start. I've spoken enough. Or Dr. Pardesi is there.
So, I would like to, thank the entire team, especially Dr. Pratik Tambe, for taking this initiative and also giving us this wonderful opportunity to interact and also.
I think her connection is lost.
She's lost again.
Yeah. परदेसी साहब तुम्ही बोला चला
बोला madam.
Okay, chalo, I would like to thank on behalf of my co-chairperson Dr. Pardesi and Dr. Malara. I think she has lost her connection. We would like, and of course both the speakers, Dr. Guha and Dr. Kalyan Barmade. We would like to thank the organizer, especially the convener of today's program, Dr. Pratik Tambe, who is also a chairperson of EMOG's Endocrine Committee, and of course TOG for giving us an opportunity to hold this program and for covering both the speakers very well covered up both the topics, one on a hysteroscopy and one on an RH management of RH ICU immunized patient. And I would like to thank, and of course all those who have logged in for today's seminar, would like to thank all of them. I would like to express my gratitude to all. Dr. Pratik, anything that you want?
Thank you so much.
And you're most welcome. We would like to have people from different parts of India.
Thank you very much.
To come and participate in our programs.
Thank you.
Thank you, Dr. Biswajit, sir. It was really nice to listen to you. Thank you.
Thank you very much, Dr. Parmade. Same here. It was very nice.
Thank you, Dr. Biswajit. Thank you.
Thank you very much.
Dr. Pratik is not speaking today anything.
As the convener, I'll just need to add a few more points to the official vote of thanks. I'd like to express my gratitude to our esteemed President, Dr. Nandita Palchetkar, our Secretary, Dr. Arun Nayak, to the ICOG Chairperson, Dr. Mandakini Meg, and the Secretary of ICOG, Dr. Parag Biniwale, for granting us the ICOG credit point. To the office bearers of AMOGS, Dr. Rajendra Singh Pardeshi, who's our Vice President, and Dr. Sujata Dalvi, who's our Joint Secretary of AMOGS. Thank you so much for being here, despite your busy schedule. Dr. Malaraj for braving the internet issues, which sometimes plague us, unfortunately. And two fantastic speakers who gave us so many take-home messages. Thank you. Hats off to you for covering the topics so well. Thank you to Science Integra and Bharat Serums and Vaccines, our education partners, the Feminora division, for the Bridging Bharat series and for your collaboration in this event. We hope to see all of you very soon. We've had over 300 delegates logged in today's event. And thank you very much for being here. We'll see all of you soon. Goodbye. God bless.
Thank you very much.
Thank you.
Thank you.
Bye.
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 Biswajit sir, bye.
Bye.
Kalyan Rao.